Oh, hey, Chris.
Hey, Chuck, how are you?
I'm doing really well. What about yourself?
Oh, fantastic, fantastic. Always good to be here recording again, and then we're going to get into one of your favorite topics today.
We are. I love elbow. That's the teaser. And what type of elbow we're going to discuss, you'll have to just hang on and see.
Is it that little bitty elbow that you posted on social media recently, or is it something more than that?
Did you like that? It was a little video. I didn't know when I printed a 3D model, I had to say I'd like life size, not miniature size. It was
The
awesome.
objects in me are closer or larger than they appear, or whatever it is.
It's so true.
So, really exciting stuff for the podcast. I guess we're a solid, 2 years and 7 months into recording and releasing episodes. Amazingly, we're still here, and I would say our podcast is thriving because we are about to reach a very exciting download milestone.
It's really, I think, pretty incredible that we are, by the time this podcast actually drops, we will be well past this milestone of
200,000 downloads.
yeah. So first of all, thank you. Thank you to the listeners. And thanks to Chris. This has been super fun. And I hope we have another 200,000 is, enough fodder for more downloads, but I'm really proud. And I hope we can stay engaging. But we want to celebrate this.
Yes, we absolutely should. I wanted to thank the Goldfarb children for clicking 200,000 times over the last 2.5 years. I'm sure they're very exhausted. No, but seriously, it's been a treat. Thank you, Chuck, for being a fantastic partner. And the listeners, of course, you keep us going, you keep us energized. We keep getting reviews and emails that just, make this a joy, to be very honest with you. We talked in the last episode about leadership stuff and how sometimes you just run out of gas on stuff. And this is one of those things where, there is a little bit of inertia sometimes to kind of get things going. But once we do, it feels really good. And, I wanted to share a review if that's okay with everybody. So we've got a great review. This one is from Joe Basante. Joe is an OTCHT in New Jersey. He gave us 5 stars, so thank you, Joe. He says our podcast is his go-to for both hand surgery therapy topics and for entertaining banter. That's clearly Chuck. I love how you collaborate with your hand therapists and how much you value how much value you place in their expertise and experience. Both of you are unquestioned experts in disciplines, yet present complex material in an understandable and relatable manner. So, Joe, thank you. You're an established therapist in New Jersey, and you work at the Rothman Institute, so we know you've got some academic chops as well. So we appreciate you writing that review. Thank you.
Yeah, thank you so much. And before Chris and I talk about the celebratory giveaway, I want to share the contents of another email because one of you, Dr. Terry Light, called us out, and we like that. We know we don't always have all the answers, and we know there's got to be bloopers out there that we could laugh at and celebrate. But I made a mistake, and Terry called me on it. And
I love how we have a fact-checking listener group here. I love that.
Love it. So my mistake was I referenced George Kettlecamp in regard to sagittal band injuries. And the reality was a couple of things. First of all, it's not George Kettlecamp. And if Dr. Kettlecamp is a listener, I very much apologize. His name is Donald Kettlecamp, and he was at the University of Iowa and wrote a paper with Adrian Flatt and Robert Molds, and it talked about sagittal band injury. So we got the generalities of the citation correct, but we made a mistake. And I think the other interesting thing is Terry's follow-up email where he said, and I agree with this, fame is fleeting. Dr. Kettlecamp was on the American Board of Orthopedic Surgery from 1980 to 1986. He was the frickin' AOA president in 1990. And I like to think of myself as a student of history of the field, screwed up his name. So my apologies, and thank you, Terry, for calling me out.
Yeah, it's amazing. For all the things that we talked about in the last episode, for all the things that we strive for, all the accolades that some of us shoot for, at the end of the day, only your family is going to remember you. So Make sure you prioritize that. But Terry, thank you for pointing that out, and I'm glad Dr. Kettlecamp has been given his shine through an email from you, Terry. So Chuck, what should we give away to celebrate 200,000 downloads?
Well, I think one thing that we have that I've been not so great about fully utilizing are books. And I read lots of books, but when you and I edit books, we typically get a copy of the book. And so I think that you and I would each like to provide a signed copy of a recent textbook that we have either edited or contributed to, and make it available for a survey winner.
Now, Chuck, what kind of narcissistic idea is that? Who came up with that idea? And you think people are going to want a book signed by one of us?
Hey, listen, it's a free book, and it wasn't my idea, but it's a free book. So I think
One
we'll
of
have
us
some
came
takers.
up with that idea. No, I think that'd be a fun thing to do. It's literally the only thing we have, but we still get asked about mugs, and I think there are a couple left. So maybe those will make their way out too. So Chuck, how does one enter into this drawing for the textbook package?
So I'm not going to disclose that on the air, Chris. Here's what I'm going to do. If you have not signed up for our email newsletter, and I promise we will not spam you too much, I'll send a couple emails about this. Go to the show notes. The sign up is there. And if you sign up, there'll be more information to come in the weeks ahead about how to qualify for the drawing for a textbook or a mug. We're also going to set up a new survey because we want to understand what you like and don't like about our podcast. And so there'll be 2 bits of information, and both will be available in the show notes. And we would really, really appreciate your interaction with that.
Absolutely. So please sign up for that on the show notes and help us celebrate a huge milestone. Now, I can't think of a better way to celebrate than to give Chuck a topic that he just loves. And, he really tried to pull in some perineal nerve. And I said, you know what, Chuck, our listeners are not ready for that yet. It's a lower extremity. It's a nerve. You're really going to push some people away. And he said, we could talk about ligament injuries and stuff. I said, okay, maybe one day. But how about we talk about something that you love, potholes in the elbow?
I do like potholes, not in the St. Louis streets, which they are way too many. And don't let Chris fool you, y'all. He wants to always talk about nerve, but I think we're going to talk about elbow OCDs, and it's going to be a focused discussion. I know all the listeners won't necessarily like the topic, but I'll tell you this: I think there's some generalities from this and some frustrations with this that maybe everyone will appreciate. So let me share a case with you, maybe as a way to get going. I have a 13-year-old female who is into cheer. And that always, for me at least, takes some digging to understand really what that means. With gymnastics, it's pretty easy. I'm a level 9 gymnast. I do this and that. With cheer, there's all kind of gradations. But she's very active, and she does tumbling as part of her cheer, and she does stunning as part of her cheer. So she's very active and was a previous gymnast. And she's developed right elbow pain. And her elbow actually lacks extension. So her elbow motion is 35 to 140, and her rotation is full. She does not have mechanical symptoms, but she has some pain and she can't straighten her elbow, and she's frustrated.
Now, was there a specific injury, traumatic episode, antecedent event that led to this?
She had some pain or aching pain in the elbow over a couple of months, but there was not one specific event, just a realization over time that she couldn't fully straighten her elbow. And
How
I'll
does
say,
one go that long without being able to noticing that you can't straighten your elbow?
I certainly would expect there was a critical event, but she didn't remember it, and it didn't cause pain. And I'll say this is not the common scenario. The common scenario is full motion, maybe some mechanical symptoms like some clicking or even some catching or locking. But this is real, and this is how this young lady presented.
Okay, so are you the first person she's seeing for this? How many people have these patients typically seen before they get to the czar, the guru, the Wizard of Oz, Chuck Goldfarb?
Highly variable, but they've almost always seen at least another physician, maybe an APP. This young lady had seen a physician who recommended rest for this. And unfortunately, that wasn't the right answer. When you really lack motion or have significant mechanical symptoms, I don't believe rest is the answer. Just to kind of go down that pathway, rest might be the answer for kids with OCDs once diagnosed, if there's no displacement of the OCD, and if the child is younger, especially rest and giving the body a chance to heal can be super helpful.
So rewind back for me and let's talk about, the differential and how you get to the right diagnosis on your questioning. Because I think of, an adolescent athlete, and even if they're not a thrower, maybe it is something that is more of a overuse kind of thing. And how do you distinguish an overuse kind of thing versus kind of pain inhibition versus an actual OCD? Like, what are the questions that you are asking on your history that are going to lead you down this route?
It's a great point. It's a great point. You do want to understand the timing and the, kind of what happened. And you don't always get a great answer, but that's an important part of the history. If it is a gymnast, you want to understand what level, what do they do? If it's a baseball player, you want to understand how many innings they're throwing and what type of pitches they throw. Those are all super important. You want to understand what's been done. What have you tried? Have you tried rest? What does rest mean? And just kind of go down those pathways. And so it's not necessarily super quick. And then you really have to do a careful exam. And so on my exam, I focus on a couple of things. Even though I might hear that there's no pain or hear that pain is lateral, I still focus on the medial elbow to start. I examine the UCL, moving valgus stress test. I examine the ulnar nerve. I examine the triceps, and then I go laterally and I examine the gutter. I want to feel the radial capitellar joint. I want to make sure there's no nerve pathology. So a comprehensive exam, which can thankfully be done pretty quickly. I will say, I'm babbling. I will say one of the things that I found of super interest lately is this pain inhibition can be a real thing in the very young adolescent, and that's often is nerve related. And the nerve findings can be subtle. And in our experience, that is Dr. Wall's experience in mine, the ulnar nerve can often be the culprit. And so again, a careful exam is super important.
Did you just bring the nerve into this? That's great.
I did. I do respect the nerve and those that care for nerves. I do.
So when you're examining, what are the specific things when you're assessing the radiocapitellar joint, when you're assessing the gutters, are there any classic moves that are very helpful to you or any moves that you have determined are helpful?
I think palpation for me is the main one. And so when I think about the lateral elbow, I start at the lateral epicondyle and just palpating directly there. And then if you just let your finger slide posterior to lateral epicondyle, you fall into what I call the lateral gutter, and that's the joint. And so in an old patient like me, that could indicate arthritis. In a younger patient, it could indicate synovitis and some type of intra-articular pathology. You can then go back to the lateral epicondyle and slide a little distal, rotate the radial head, feel the radiocapitellar joint. And for most with a symptomatic OCD, that's where they feel pain. And then you do have to differentiate this, different populations. But if you feel that lateral epicondyle and go just anterior, then you're in lateral epicondylitis turf. And then if you go a little distal, as you know, we'll talk about that inward again, you can fall over the radial tunnel. And so the four things I think about laterally are joint-based issues, ligament-based issues, tendon-based issues like tennis elbow, and then finally radial tunnel.
So how do you then go to work these patients up? Does every patient get radiographs? And then how often are those going to inform management for you? And then when are you moving towards advanced imaging?
Everyone gets a radiograph, sometimes bilateral if I think it would be helpful. Usually the radiographs are helpful, but they probably don't tell the whole story. So if you're really concerned about an OCD, an MRI is almost always indicated in my mind. And insurance companies don't fight us too much on this one, although we'll come back to insurance companies later. But the MRI usually tells the tale. Is the OCD, how big is it, number one? Does it involve the lateral wall, number two? Is there a loose fragment, number three? how does it guide potential treatment? What's the, the depth of the cartilage issue? So lots of information. We could talk about this ad nauseum, but the MRI for me is always helpful.
So before we get too far into this, can you define what an OCD is for the listeners? Because we have people of varying backgrounds and training levels, et cetera.
Yeah, I think different people use it to mean different things. So it could be osteochondritis dissecans, or it could be osteochondral defect. And there may be some out there who are laughing at me, but I use those somewhat interchangeably. The defect obviously implies an OCD, which is using the osteochondral defect, implies a bigger displaced lesion in my mind. But I think people use those terms interchangeably, both as OCD. But the reality is this is a death of subchondral bone and subsequent pathology to the overlying cartilage. And I think most people believe there is likely a genetic component. There's a hypovascular issue. There's a trauma or repetitive trauma issue in many, and sometimes there's an acute trauma event in some. And so all of those factors come into play, but ultimately, if you get an OCD, then unfortunately, it can be a difficult problem for a young child who is often very involved in athletics.
What happens if the OCD goes untreated? Is it something like a snack or like a scaphoid non-union that we think predictably would go on to a specific pattern of arthritis?
I think if you have an OCD and you don't rest, then you risk. I don't think there's any good natural history studies that I know of. The best literature is from our Japanese friends who seem to have a higher incidence of this, and perhaps related to, baseball fanaticism. But I think it's safe to say if you have an OCD and don't rest and continue the trauma, it'll lead to a displaced fragment, which can cause joint problems and ultimately require treatment. Whereas early on, if you rest appropriately, and what does that mean? 6 months? Probably. Some would argue even longer periods of rest, but that gets really hard for our population.
When do you pull the trigger on the MRI? If you know you're going to have to rest them initially, do you do the rest first, keep the clinical suspicion in your head, maybe talk about it with the family, or do you get the MRI for the jump?
For me, in our role as a tertiary care center, often where the patient's seen several different providers before seeing us, I get the MRI at the start. And I think you kind of have to understand what's possible. Is it possible that this will heal? Are the growth plates open to increase the chances of healing? Is there a loose body that you couldn't appreciate on the x-ray? You kind of want to know all those things. And then if it's a non-displaced OCD, and the family is reasonable, and I would push them to be reasonable, then you give it a period of rest and you explain that you can't promise it'll heal, but that's your hope. And I think it does. I think there's a good chance for the right kind of OCD to heal. But then obviously you have a group of patients where it doesn't heal or it's too late.
And is it ever too big to not heal?
I don't know. I mean, certainly the size of this lesion matters a lot. I think many of them will heal despite their size if they're just in the right biological situation, a young enough patient who really does respect and stay off of the elbow. Yeah. And then, so the way I think about these is, I think, pretty straightforward. If the fragment is displaced, then surgery is indicated. And if I think about surgery, and certainly there's some gray areas, but when I think about surgery, I think about, can I repair the fragment? Can I stimulate a marrow response and get fibrocartilage replacement of the lost hyaline cartilage? Or do I have to think about ways to bring in new bone and cartilage to get this thing to heal, to give the kid the best chance of a good outcome? And so
When you talk about, sorry, I didn't mean to interrupt you.
No, please.
When you talk about displacement, because it's death of subchondral bone, is it just that you have a sinking in of the area on top of which you have the subchondral bone death? Or is it actual displacement in the sense of maybe it's riding high, it's shifting out, causing an actual area for, point loading of that specific displaced fragment? Or is it more point loading of the areas around it?
Yeah, I think it's a matter of, you do get loading around it. It's just a matter of, will the cartilage fragment break off? And typically it's just that overlying cartilage which breaks off, and the underlying bone just stays unhealthy and sits there. And so the primary treatment, the so-called debridement and microfracture, is simply about creating channels of bleeding bone that'll allow progenitor cells to populate this area and create fibrocartilage, which can be a sufficient substitute cartilage to get kids back to play. So pretty cool, and really can work. And we've done a few studies in this area, and many others have done studies in this area demonstrating that this microfracture for the elbow really can be successful.
How, for those listeners that have trained in orthopedics, how different are these elbow OCD lesions from the ones that are encountered in the knee?
I don't know that they're fundamentally different. I think they're less worrisome because you're not theoretically weight bearing on the elbow. At least you don't have to weight bear on the elbow. So I think they're a little bit of less stress, and we certainly learned a lot of lessons from treatment of knee OCDs, and taking those lessons to the elbow. At least, we haven't really taken all the lessons from the knee, but some of the key ones.
So what are the different treatment options? And, we've talked a little bit about rest. Is there any role for, injections of any sort, whether that's steroid, hyaluronic acid, or some visco supplementation? And then talk to me about the different surgical options and when to use those.
Yeah, I personally don't believe there's any role for injections. There's no literature to support that. I saw a great family last week who came down from a few hours away, 4 or 5 hours away, and they had gotten injections in the elbow, and they felt better. And then they had these displaced OCDs, and they weren't going to heal. And so it creates this artificial sense of things are better. And I think that can lead to more damage being done, honestly. So I'm not a big fan of injecting kids' joints anyways. Sometimes I'll do one in the right situation, but not for me. There's no injection that's appropriate for this issue.
Not even PRP?
Not even our friend PRP. I get that one a lot. So the hardest ones of these are when you have pain, failed conservative treatment, and when you go in to do your elbow scope, the overlying cartilage looks intact. And then you probe it and it's loose or flakes off, and you just get this sinking feeling in your stomach where you're taking away what appears to be healthy cartilage that has absolutely no support beneath it. And so you create the lesion in some respects, and then you ask the body to heal this with new cartilage. But that unsupported cartilage over the dead bone does not heal. And
so you mentioned inspection on arthroscopy. Is it always arthroscopy? Is there ever a role for an open surgery? Or is arthroscopy just part of the not only treatment, the diagnosis, or confirming the diagnosis, establishing prognosis?
I think it's got to be arthroscopy. I mean, you certainly could open an anconeus splitting approach to the elbow as part of what we did for this young lady. But I think arthroscopy is the tool, because you can really get information about the whole joint. You can debride inflammation or synovitis, and you can really assess the area of concern.
So you mentioned about microfracture techniques, maybe even bringing in some, a plug or something like that. What are the different surgical techniques that you use, and when do you use them?
I would say the most common is a microfracture, at least in my hands. If a OCD, and some of these numbers are somewhat arbitrary because it does depend on the size of the child and the growth plates and the like. But as a general principle, the lesion is less than 1 centimeter in diameter in the center of the capitellum, I will try a microfracture. Once it gets more laterally, and that kind of the elbow where the capitellum ends, that lateral wall is really important for stability. You don't want the radial head escaping, because that creates a whole nother set of problems. And so if it's centered in the capitellum, in a small enough lesion, a microfracture is appropriate. When you get more than 1 centimeter in size, then you have bigger problems. One of the tricks and challenges that we have is that insurance companies largely refuse to pay for an OATS procedure. So an OATS is when you take essentially an osteochondral autograft plug. You can use an allograft, but for me, I like to take a plug of bone and cartilage from the knee, from the lateral proximal cartilaginous portion of the knee. And the beauty of this approach is that it heals quickly, reliably, and you can essentially take a 1 centimeter plug or bigger, or 2 plugs, and you essentially put those in the capitellum. You create a smooth surface, and what you're asking the body to do is heal the deep bone. That's why you harvest a centimeter deep plug or something like that, and you ask the body to heal the bone to bone deep, and then the cartilage stays alive on the surface. And you can, it's remarkable. It's a reliable technique. It's probably the most reliable technique in my mind. It does require going to another joint. Insurance companies routinely fight this and often deny it. And there's literature supporting it. It's one of my greatest frustrations with interacting with insurance companies.
Is it that they think that it doesn't work, or they're just not? I mean, we could probably get into a whole thing about insurance companies. Have there been payers that have changed over the last couple of years and actually started to accept it?
To my knowledge, no. And I can't say that every insurance company rejects it, but every time I schedule this case, it seems to be rejected. I do a peer-to-peer, and like you said, or someone said recently in a discussion, you have the peer-to-peer, but the reality is you're just wasting your breath, because they're going to say, well, it's considered experimental, we can't approve this. And that's what they say, and it's not experimental. And there's good orthopedic science to support it, and there's good anecdotal evidence that it works, and yet we can't always get it approved. And so it's frustrating, because it's a great, great operation.
So do you typically harvest the plug on your own? Do you involve one of our sports partners? And where do you take it from the knee without it being an issue in the knee? You mentioned kind of the proximal lateral aspect, right?
Yeah, so the first couple times I did this, I worked with my sports partners, but it's not hard. It's a lateral parapatellar approach. Actually, it's not exactly accurately stated. It's a lateral approach to the patella, and then you use one of the Z retractors, retract the patella. There are great kits designed for harvesting the plug, and it's that very proximal lateral cartilage on the anterior surface of the knee, and it's non-weight bearing. It doesn't have any interaction with the patella, and so occasionally it is a source of frustration for kids, but almost always it's just extraordinarily well tolerated. So fun surgery, effective surgery, and I really like doing it when we can, make it happen. The last
So the question is, do you wear your loops when you're harvesting?
For sure. Wouldn't you?
Well, of course. I wear my loops when I nail a femur.
I feel naked in the operating room without my loops, and I get made fun of, and I'm fine.
I was doing a wrist scope recently, and I have my loops on. They're like, why are you wearing it? I was like, why you don't?
Yeah, I need that weight. I need that comfort. I absolutely wear my loops. And
so
just
sorry.
No, go ahead.
I was gonna ask, when you inset the plug, is it purely interference fit? Are there any additional forms of fixation? How are you doing that?
Interference fit. Never had a problem, knock on wood. And sometimes you have to contour it a little bit, because the capitellum's curved, and this is sort of a flat piece of bone and cartilage you're harvesting. But yeah, I see the appeal of sports medicine. Obviously, I like wrist scopes and elbow scopes, and I like working with my sports partners. And you and I are going to have a future episode about that. To close the book on this topic and this patient, this young lady had a really interesting thing. She had a 14 millimeter OCD, loose fragment, floating in the joint. It was actually hard to get in the posterior joint because this fragment was so big, and it was a massive part of her capitellum, because she was not that big. And there was a really thin layer of bone, but because it was so massive, ideally these fragments they break off have bone on them, because if there's bone, there's hope for bone to bone healing. Cartilage itself is not going to heal, but if there's bone on the fragment, it might heal. There was a little bone, and because it was massive, we went ahead and fixed it, which was really satisfying, but I don't know if it's going to heal. But I felt like there are different tricks and tools out there. I used what's called a micro nail. It's made by a company called ConMed. I've never used it before. I really liked it, but I think there's a lot of little things out there. They're bioabsorbable. I put 2 of them in it. It was very slick. I could have used a headless screw. These things have a little bitty head on them. It was really satisfying. It'll be more satisfying if the fragment heals.
Of course. So, and thinking about that case and reflecting on her preoperative exam, why do you think she couldn't extend her elbow all the way? Was that she was, the abnormal contact pressures at that area right on her capitellum every time she tried to extend?
It was a physical block because that fragment was loose. And so in the operating room, she had full motion, which is always also very satisfying. Now, if this thing doesn't heal, we're going to have to push the insurance company to approve an OATS procedure. But I'm hopeful, cautiously hopeful.
So then to bring in our therapy colleagues into this, what's your post-op protocol after, maybe not this case, for example, but maybe after an OATS or a microfracture?
Yeah, usually you're just trying to get the elbow moving. I don't splint these patients, bulky soft dressing to start. I kind of tell them to move at home, and then I see them back at 2 weeks. These are kids that, they don't tend to get stiff. And so I check them at 2 weeks. If they have their motion, then I just tell them to wear a sling as a reminder, at least for the first 6 weeks, and try to keep their activities limited. And then at 6 or 8 weeks, I often will start to do some light strengthening, but I protect these patients for a while. So an OCD treated with an OATS is usually healed by 3 months, and then they can ramp up their activities tolerated. An OCD treated with a microfracture, I actually protect them for longer, 4 to 6 months, and usually get an MRI. Not everyone does a repeat MRI, but I often get an MRI to assess healing. And then if you fix the fragment, which for me is really uncommon, because I can't usually find the indicated, I can't find the fragment that needs to be fixed, but those I go slow on also. I need to make sure we're healed before we go back. So not a huge therapy need for these kids, but there can be, I guess I would say, sports related rehab to get them ready to go back to their sports, make sure their mechanics are okay as they kind of, reincorporate into their favorite activity.
So when do patients age out of having OCDs? A getting older guy like me versus an old guy like you, are we going to get OCDs in our elbow?
I think I'm just gonna get plain old arthritis. I don't know about you, but I think what happens is, usually once the growth plates close, I think it's pretty rare to see a new OCD. Now I'll see OCDs with closed growth plates, but I think those develop before the growth plates close and just persist. But I think you don't really see them above the age of 15 or 16, or at least I don't.
Okay. Well, thank you for educating me. I learned a lot about OCDs, more than I'm ever going to want to remember or ever need to know, because I'm just going to send them to you. But thank you. I think that's going to be a very educational episode for many.
I know my penance is probably going to be 2 nerve topics, and I don't know what else.
That's okay. We'll make sure to give people what they want, and that'll be part of the new survey that's going to come out. So those of you that sign up, we're going to do another survey. You'll enter to win the books, maybe get some extra swag out there. And thank you everybody for always supporting the podcast. Really appreciate it.
Absolutely, we are grateful beyond belief. Hey Chris, this was fun.
This was fun. We'll see you next time.
All right.